So the first thing we're going to do is the quiz. You will need to go to Blackboard. On the menu on the left, I've added an area for online tests and quizzes. This shows that it should be available. Let me go back and make it available. I'm not sure why, because the time says it should be. Okay, you have a case study quiz. You will have 15 minutes to complete the quiz. So I want everyone to go and do that now. You find it on Blackboard. Scroll down on the left side menu. There's a new content area, online tests and quizzes. Okay, so everyone who was able to access the quiz today has completed it. I won't be able to do the review because a couple of students were not able to access it due to internet issues, and they'll have to take the quiz next week. Sorry. So the next thing we're going to do is look at some fetal monitor strips. And I want you to look at these strips and interpret them, but I want you putting your answers in the chat, please. Okay, let's see if I can make this one a little bigger. Doesn't want to go bigger. Okay. So in the chat, we only have one contraction, so we can say how long that contraction lasts. So tell me how long that contraction lasts. Okay, good. It's lasting 60 seconds, about a minute. Now, are you able to see the fetal heart rate baseline? And I'm going to give you, because this is pretty tiny, this red line where my cursor is 120 beats per minute. This one is 180 beats per minute. So about where is the fetal heart rate baseline for this tracing? Okay, so about 140. This is really difficult to follow, to see. So you guys did a good job. Now, can you tell me about the variability on this strip? Okay, the term that we use is minimal. Everybody's getting the right idea. I would say this is barely minimal. If I could see the strip better, I'd try to make a determination if it's minimal or absent, but it's very, very minimal variability. Okay. Now, are there accels on this strip? No accels. Are there decels on this strip? There's one decel. What type of decel is this? Okay, you guys have this. So this is an early decel, and we know that because when the contraction is over, the decel has completely recovered. Okay, so this is minimal to absent variability, no accels, there is an early decel. What category is this strip? Okay, this is a category 2 strip because the variability is minimal maybe even absent. If this were a late decel, I would consider calling this a category 3 strip because the variability is almost just not there. And with this is not a very good quality image. So looking at the strip, you might be able to see better, but this is a category 2 strip. Okay. Are you able to see a different strip now? Okay, good. That means I won't have to go back and forth and share and unshare. So tell me about the contractions in this strip. Sorry, I'm going to stop the share real quick to make sure I did. I was just making sure I restarted the recording. Okay, tell me about the contractions in this strip. Okay, so Amanda, what's 2 minutes? Okay, so the frequency is about 2 minutes. The length is how long is the duration? What is the duration of the contractions? We talk about frequency, duration, strength, and resting tone. So the frequency is every 2 minutes. The duration, we've got one over here that's 3. The duration is about 60 seconds. Okay. This could be, I don't see an indicator on the strip, but if this is an internal monitor, how strong are they? If the top's 100. Okay, so about 85, 90 millimeters of mercury. And what is the resting tone? I can't tell if that, I think it's around, I think this might be 20. No, that looks like 25. So you're right, about 20. And again, this is hard to see because the image is not fantastic. Okay, so what is the fetal heart rate baseline? We're trying to kind of trying to guess, right? Let's see. I believe this is 120 and this is 150. Right here is 150. Okay, so let's call this baseline 150. It's really hard to see the markings on this strip. I wouldn't want to read this for an actual patient. I'd want better markings. So what is the variability? Okay, minimal. And this truly is minimal, I think. I think we've got a little bit going on there. Are there any accels? Okay, no accels. Are there decels? What kind of decels? Okay, so we've got late decels, and we know they're late because when the contraction ends, the decel has not recovered. They start toward the middle of the contraction, but what really determines if it's a late is the recovery. So contractions over, decels not fully recovered. So we've got minimal variability, late decels. What category is this strip? Go back and review the guidelines for a category 3 strip. Okay, this is category 2. Remember that a category 3 strip is no variability and decels or no variability and bradycardia, okay, or a sinusoidal pattern. So if they have any variability, it's going to be a category 2, either category 1 or 2, okay? So let's go to the next strip. Oh, it disappeared on me. Okay, This one, it's harder to see the numbers. So we have contractions about every 1 to 2 minutes, and they're lasting about 50 or 60 seconds with some coupling. Okay. Can't tell if this is internal or external monitor. But they're only marking up to about 40 millimeters of mercury here. Now, can you see where the fetal heart rate baseline is? This is this line right here is 140. So the fetal heart rate baseline is about 140. What variability do we have here in these spaces where the heart rate is at baseline? Well, I've got everything. Okay, if you think it is minimal, what qualifies this as minimal variability? What is the determining factor for minimum variability? Less than six beats per minute range. Does this look like a range less than 6 beats per minute? This space right here. We've got several of these spaces where it's back up. This range, so we've got all these spikes, that's greater than 6. So what is moderate variability? Six to 25. Okay. So this is down to 130, and we've got this up to about 150. We've got over here 130 and 160. And actually here, we probably are moderate, but if you look at each one of these little spaces where it's back to baseline, the variability gets increasingly more. This is definitely marked. Do you see that trend? So why do you think the variability is becoming more marked later in this strip? Yes, the baby is experiencing more stress. Now, let's talk about the decels. I don't see accels, I see spikes, but not accels. So what kind of decels are these? Those are very deep, variable decels. Sorry. Those are very deep, variable decels. They go down to, it looks like 60 beats per minute at the nadir. I've seen deeper ones, but these are pretty deep. And they're with every single contraction. So the contractions are every about 1 or 2 minutes with coupling. And so every minute or 2 minutes at the most, the longest this fetus gets to recover is about a minute in between. So the big drop to 60 and then back up. So what do you think is going on here? Okay, there's cord compression, because moderate variability in between shows that the fetus probably has an ability, has pretty good placental perfusion. And these big, deep, sudden drops are the cord getting compressed. But the cord is getting compressed pretty badly every single contraction. According to the legend here, it says this is a term human fetus with a cord prolapse in early labor. So this is going to have to be a C-section. The cord is trying to come ahead of the baby. If the baby is doing this, if we've got a fetal heart rate doing this early in labor, they're not going to continue to tolerate this for very long. We can already see changes in the variability from here to here. Okay, let's look at the next one. We've got 2 contractions. How far apart are they? About 5.5 minutes. Remember, we count from the beginning of a contraction to the beginning of a contraction, not from the end to the beginning. So beginning of the contraction to the end. They're lasting about, this one's almost 2 minutes. This one is about a minute. So they're not really consistent. This looks like it's more likely to be an external, just because this baseline here on the contractions is kind of up and down. That could also be some uterine irritability, but I can't really determine strength or resting tone from here. I want to palpate. So before this big decel, what do we see? This is 120, 150, 180. So where is the baseline? About 140. What's the variability? We're going from 130 to 160. I would say we're going from probably 120 to 160. No, that's 120. Okay, so from about 140 to 160, so moderate. Okay. Can't tell if this is an Accel because we don't have enough strip to really see what the baseline exactly is. That might be a little Accel. But we have this decel that starts in this with this long contraction. And then the contraction ends and the decel just continues to go. So this is a prolonged decel. How long does it last? Look from when it begins all the way until it's recovered. So about 4 to 5 minutes. Let's look. 1, 2, 3, 4, almost 5 minutes. Okay. What is the nadir? That's the lowest point of the decel. And I believe I'm trying to make it out. This might be around 100. Okay. Yeah, that's kind of where I am, Zach. It's hard to see, but I'm thinking maybe around 100. When it recovers, what do you notice is different? From here, this is the baseline before, this is the baseline after. So the fetal heart rate baseline is higher after recovery. Okay. It's close to 160. What else do you notice? The variability is decreased. It's gone from moderate to minimal. And this is probably barely moderate, but this is not unsurprising if I don't get concerned about variability like this, but this is less, this is minimal. So what does that show? Increased stress. This big decel stress that fetus out. Well, that makes sense, right? Because whatever's happening here for about 5 minutes, the fetus wasn't getting adequate oxygen. So this is the response to that. Now, if this doesn't happen again, the fetus may recover to better variability later on. But if it keeps happening, this stress is just going to keep getting worse and worse. It's cumulative. And it actually looks like toward the end of this, I can't tell if the baseline is going down, or let's see if we can see more. It looks like the baseline starts to go back down pretty much to where it was. So looks like they're recovering some here, getting a little variability back, still minimal, but it's getting a little bit back. Okay. So let's move on to the next. Oh, what would you call this strip? Category 1, 2, or 3? Category 2. Good. And as a nurse, what would you do with this strip? What would you do at this point right here? What are we doing? Okay, over here, we're repositioning. We want to get her on her left side. If she's on Pitocin, we stop it. What else do we want to do? Okay, if it's not recovering, we're notifying the provider over here, right? If it recovers here, then we're going to let the provider know. But if it's not recovering, somebody around here is probably calling the provider and saying, hey, we've got this going on. I would probably check the mom's vital signs, especially if I think there might be something that's happened here. I've seen something that looked like this when we started an IV because the mom had a vasovagal response to the IV stick. Then it recovered, everything was fine the rest of the time. Temp, probably not any more often than usual because tachycardia can indicate that the mother has fever, but in this case, we can see a definite reason for this change in baseline. If it kept on, I would check the temp. But we can see why the baseline changed right here. Now, this recovers, and what are you doing? And I saw it up there earlier. What are we doing here? Monitor, and we want to make sure that the provider is aware because they're probably not going to come over and do a C-section. If it's recovered, they're not going to come over and do C-section right now, but they do need to be aware so that they know they may have to come quickly. Okay. All right. Now let's look at the next one. Let's look at the contractions first. How far apart are these contractions? Like 1 to 1.5. They're pretty close together. How long are they lasting? Okay. 40 to 50 seconds. Some of these are like, if they last longer, it looks like there's a little more space. So maybe 50, 60 seconds for some of them. Okay. If this is an internal monitor, how strong are they? $60 to $80 seconds, resting tone, 20. Okay, this may be an external because usually we default the resting tone to 20 on external, or we used to. But if it's internal, that resting tone is 20. Okay, fetal heart rate baseline. It tells you on the strip. 180. Okay, so this is this within normal limits? What is it? Tachycardia. Okay, so variability, moderate variability, accels, decels. I don't see either accels or decels. This is variability. That's just a little notch there. I don't really see accels or decels. I see variability, but no accels or decels. Okay. Category 1, 2, or 3. Okay, category 2 because it's tachycardic. Now, what is one assessment you want to make based on this? Mom's temp. Yes. Sometimes a preterm fetus will be tachycardic, but it's usually not 180. If they're this tachycardic, the mom more likely has a fever unless there's some cardiac issue. So I would want to check mom's temp. All right, contractions. Frequency of contractions on this strip. Okay, probably 1 to 2. 1, 2. 1, 2. Looks like this one might have been 1.5. Okay, how long do they last? Duration. Okay, 45 to 50 seconds. Mostly this one lasts longer. It's about 1.5 minutes. Okay. If this were internal, that would be up to 50 to 60 millimeters of mercury with a resting tone of 10, right? Now, fetal heart rate. What can you tell me about this fetal heart rate? Bradycardia and minimal variability. Okay. So bradycardic at 100 beats per minute with minimal variability. This you may see when they're post-term sometimes. Now, what category is this strip? No D cells or AC cells. Good. Category 2. Okay, next one. Got to enlarge this one a little bit, and I don't know how well. Oh, we can see the numbers pretty good. Okay, contractions. This is clearly an external monitor. So we can see the contractions. How far apart are they? These are 2 minutes of, well, these are about 2 minutes apart. These are about 5 minutes apart. So you could say 2 to 5. Okay, you can give a wide range. 2 to 5 minutes apart. They're lasting how long? $60 to 90 seconds. I'm going to want to palpate these for resting tone and strength. So fetal heart rate baseline. 150, variability. Absent, I see nothing here. D cells. We've got a variable D cell here. Okay. Category 1, 2, or 3. Category 3. Remember that most of your category 3s are going to be absent variability. Okay. This is a provider needs to intervene pretty quickly. Strip. If they have no variability, the provider needs to be getting that baby out. Okay, can you see this one? Let's look at the contractions. First of all, if you put a baby on the monitor and you see this strip, what are you going to do first? Why? This is called sinusoidal rhythm, and it is not a good sign. So you're going to contact the provider if you see this. So sinusoidal in about 130, 140. Okay. So this is a, what category is this strip? Category 3. Okay. Are we having some contractions? Yes. We're more worried about this sinusoidal rhythm though. And it looks like toward the end, it is starting to trend downward a little bit. So this is a category 3 strip. Call the provider immediately. Okay. We do not have contractions for this strip. What is the fetal heart rate baseline? 170. Do we have any variability? So absent variability. These decels are happening in relation to the contraction, most likely. And it would really surprise me if they're not late. Okay. We can't determine that because we don't have contractions. But if we have no variability, absent variability, and late decels, what's the category? Category 3. Good. Now, when you have a patient who is having late decels, do you think that the decels are more concerning if they're deep or if they're shallow? And we're talking about late decels. Great, you remembered. So shallow lates are generally more concerning than deep lates because shallow lates show that that fetus cannot alter their heart rate in response to anything really. They just are not tolerating it. And you will sometimes, if there's a paper strip, sometimes you'll see nurses lay the strip out and look down at long ways to try to see if there are shallow lates. Okay. All right. So the next thing I want to do, I want you to go to your Nurse Think materials. And I want you to go to Nurse Think Complete RN. Go to the notebook. Go to the notebook. And I don't know if it's loaded. It is. No, maybe it's not. I think it is not loaded on this computer. So in the notebook, I want you to find the notebook page for preterm labor. I'm going to unshare and see if I can find. Okay. So you are taking care of a patient with preterm labor. What are the things that you need to know about preterm labor? What are the concepts that you need to know? Think about what are the things you need to think about with preterm labor? Gestational age. Why do we need to know about gestational age when that patient has preterm labor? To determine viability. Also to determine what else are we determining besides viability when we look at gestational age? We're trying to get an idea how developed the lungs are. So we're looking at the level of care that that infant is going to need after delivery if they were to deliver at that time. Okay, do you have your notebook page out? Okay. Got some that do, some that can't get them to work. I want you to go back and look at this and use those prompts to try to figure out what are the most important things that you need to know. Okay. So what are the highest priority assessments if your patient has preterm labor? So what are the highest priority assessments? We already know gestational age is a priority. What else? Fetal monitoring, maternal vital signs, due date or gestational age. What else? Maybe probably not a BPP. History, we want to know the history of previous pregnancies, good. And we want to know if there's anything in the mother's history that would indicate greater risk for this baby. Have they had preterm babies before? Are there any other things? Okay. So what labs or diagnostic tests would you want to see for this mother in preterm labor? Okay. H&H and platelets. We're not going to have a group B strep on a preterm. They do it at 36 weeks or 38, usually 36, I think. Okay, you might see them do an ultrasound to determine cervical length. Focus just on the preterm part. It is very possible to have other things going on, but we're focusing just on the preterm part right now. UA, yes, because a urinary tract infection can trigger preterm labor. What about fetal fibronectin? What does it show? Looked like you were typing that as I said it. Fetal fibronectin can give us an idea of whether the patient, a negative fetal fibronectin indicates they're not likely to deliver in the next couple of weeks. So if it's positive, then we're going to be watching that patient more closely. It's not very predictive, but it's much more, it is a better negative prediction. Okay. How is a fetal fibronectin done? Okay, vaginal swab. All right. Priorities of care. What are the priority interventions for that patient? Okay. Are we very successful at keeping the baby in very long? We've got an answer that's keep the baby in as long as we can, but are we successful at that? Okay, early recognition is good. Yes, steroids to increase development of the lungs, getting them to a bigger hospital for preterm babies. So if it looks like they're likely to deliver, then the things that we're doing are meant to protect. If their water's broken, risk of infection. Okay, so the priorities are primarily, why would we give mag sulfate, Amanda? The priorities are primarily to detect it early, and we want to try to get that baby transported until in order to a higher level of care before the baby's born. The medications that slow labor are not really effective at stopping delivery. At best, they can delay it for a day or two, which gives us time to get in some Yes, to get some steroids. Good, Crystal. That gives us a couple of days to get that patient transported and get some steroids in for lung development. Prophylactic progesterone is more likely to be effective at preventing miscarriages early in pregnancy. There really is not much that can prevent preterm birth in terms of medication. Sorry. Okay, Amanda, I saw you answer that question. If they are a very early preterm, then they are probably going to get some mag sulfate. That does decrease contractions, but only if they're probably not going to deliver anyway. If it doesn't slow their contractions, if they're going to deliver preterm, it usually doesn't do a lot to slow the contractions very much. It may for a day or two. But the primary reason we give mag sulfate is not to stop labor, it's to help decrease the risk of cerebral palsy. So, okay. Let's take a break about 10 minutes, and then we're going to come back and we're going to do some case studies.
This meeting is being recorded.
Okay, sorry, I think my end was unmuted during the break. So I hope I'm not sure what you heard, just pretend you didn't hear anything. We're going to talk now about some case studies, and these are case studies I've pulled from my experience mostly quite a few years ago. The first one, the patient presents to your labor and delivery, completely dilated, breech, the fundus appears very small. What questions do you ask? Okay, when did this happen? When did this start? What else? How's your water broken? What's your due date? Okay. I don't know what my due date is. Okay, how many pregnancies? Maybe. She's breech complete. Last period. Okay. What do you assess? Oh, have you had any prenatal care? And Celine said, calling the doc ASAP. Yes, absolutely. In this case, it was a teaching hospital, and we had residents literally on the unit around the clock. They slept there. So we called the resident to the room, and we were doing all of this assessment kind of at once, and the resident was there within a few seconds. So we assessed the fetal heart rate. What else? Assess the pattern. What else do we assess? Mom's vitals, contractions. Contractions probably don't matter that much at this point because she's complete. Probably don't have time to assess glucose right now. What do you do? Start an IV is probably the very first thing you're going to do if she's already complete, because she's going to C-section with this breech baby. So here's some of the information you wanted. Last menstrual period was prior to her last baby. The last baby was born August 9th. The fetal monitor shows a baseline of 160 with minimal variability. There are accels. So if her last menstrual period or her last baby was born August 9th and she hasn't had a period since then, about how far along would she be right now? So if her last period was August, let's see. June, May, 9th. Okay, so if her last period was August 9th, should be due around May 16th. But remember, after that, it wasn't a last period, it was her last baby. So she's probably the earliest menstruation after a baby probably would be around 4 weeks. So the earliest she would have gotten pregnant is 2 to 4 weeks after that baby was born. So we can move that May 16th more toward the end of May. So how far along would she be now? Let's just say her due date was May 16th. How many weeks would she be now? We can get out a calendar and count, or you can find an app. Around 25 weeks. You're correct. So in this situation, it kind of fell out that she was somewhere between 23 and 25 weeks. So what was our concern at that point? Not just, we're definitely preterm, but if she's somewhere between 23 and 25 weeks, we're concerned about viability. So we went to an immediate C-section. We did have residents on the unit, and they got somebody there who did an immediate C-section. As a nurse, what else am I doing in that situation? I'm doing all the comfort, trying to keep her comfortable mentally and physically, and trying to explain to her as we're going, she's already complete, too late for steroids. Lots of support and therapeutic communication. Explain what's going on. Good. That's why we're usually whoever's closest to that person's head is doing the explaining, and people are starting IVs and placing catheters and throwing everything on the bed and pushing the bed down the hall all at the same time. So someone needs to be explaining what's going on during this process. All right. It did turn out that the fetus, according to the way we look at gestational age, there's a guide for estimating gestational age, and that fetus did turn out to be viable, by the way, and I think survived and did okay. But the other thing that we would do as a nurse, when we're going to the C-section room, the OR for C-section, is someone needs to contact a special care or a NICU nursery team to come take care of that baby at birth. Okay, next one. Okay, I am so sorry. Well, I'm surprised that took as long as it did. One of my kids knocked on the door. I'm really shocked. Okay. The next one, the patient presents at 28 weeks. You're the labor and delivery nurse. Complains of cramping pain and watery discharge. What do you ask? Okay, what color's the discharge? Is there blood in it? When did it start? Have you had sex recently? Okay. Why would that be relevant? It's not a wrong answer, but why would it, why would it be relevant? Penetration probably is not going to rupture the membranes unless, actually penetration is not likely to rupture the membranes anyway. If the water has broken and they've had sex after that, it's an infection risk. We don't usually rupture the membranes just with an exam with fingers, so penetration won't do that. What do the cramps look like? Okay, so also maybe thinking STD. If someone in later pregnancy presents with watery discharge, the first thing you should be thinking is their water broken? Okay, have they had a rupture membranes? So those are some things you want to ask. What does it look like? What color is it? Can you describe the cramps? I probably would not get into whether they've had sex unless they've mentioned that, or if their water's been broken for longer than a day. Okay. What would you assess? Fetal heart tones. You're thinking, Ashley, you're thinking of pH paper, and it's usually more dark green color. So vaginal exam, that one is oh good, Crystal, movement of the baby. Vaginal exam is a really not controversial, but it varies, because if her water's broken at 28 weeks, if we do a vaginal exam, we increase the risk for infection. She's cramping. If she's having signs that she's near delivery, we want to do an exam, but if not, we might want to hold off on that exam, because we can introduce infection and we could get her another couple of weeks for development. We want to check maternal vital signs and fetal heart tones. I understand where you're going with that, Alicia, but we usually don't do that right away unless it looks like they're trying to deliver right now. So what do we do? Mom has cramping pain, 28 weeks, cramping pain, watery discharge. What do we do? They're probably going to order steroid shot. So that's something, we can't give that without an order, obviously, but that's something that we can expect an order for, and we might ask about if they don't. Encourage bed rest. Pad count, we want to know how much fluid is coming out. Bed rest, we want her on her sides for sure, not flat on her back. Hydrate. Trendelenburg position is usually used to keep, it's used either to keep the fetus off of a prolapsed cord, or I've seen it used if someone has preterm labor really early and they're trying to give them a few more days for the steroids to work. Okay, if she's in active labor or appears to be in active labor, we can try to get her to a facility that can care for a 28-week baby. We want to contact the provider. Probably is going to get an IV. They usually do not give meds to stop contractions if the water's broken. Now, we don't know for sure that her water's broken, but as part of our assessment, we notice that her pants appear to be very wet. We continue to see fluid. So that indicates it's more likely to be, they might do an ultrasound to check fluid levels. That's not an independent nursing intervention, but we're definitely going to hold and monitor that patient, and probably the provider is going to want an ultrasound. So we notice that her pants are wet. We continue to see fluid. The pH of that fluid is 7 to 7.5 using pH paper. She's having contractions every 5 minutes. They palpate mild. Fetal heart rate is 150 with minimal variability, but it's very hard to keep the fetus on the monitor. Temp is 98.4, mom's pulse is 83, respiration's 18, blood pressure 112/70. So now that patient is being held and monitored, what are we monitoring for? They probably are going to do an ultrasound to see the position of the baby. We're monitoring for increased contractions. What else? Okay. Fetal heart tones, fetal movement. Okay. What's the major complication that we're looking at? You're thinking of cord compression, which is one of them. What's the other major complication that we're potentially looking at? Infection. So how do we monitor for infection? Temp every 2 hours and fetal heart tones. Those are the things that we're monitoring. Now she's also going to be getting daily CBCs because we want to see if her white count's going up, things like that. But as a nursing assessment, you're going to see elevated temp and elevated fetal heart rate. Cord prolapse, the way we assess for that first is to check fetal heart tones. And if the fetal heart tones are okay, then that's what we look at first. Now, if there are fetal heart rate decels, then we would assess and see if there's cord in the vagina. Okay. Okay, patient presents to your labor and delivery unit. She's had no prenatal care. She states that she hasn't felt the baby move today. What do you ask? Good. When's the last time you felt the baby move? Has she had any sort of trauma? Has she been in an accident? Does she know how far along she is? If not, when's her last menstrual period? Okay. Okay, what do you assess? Any vaginal discharge, bleeding or fluid loss? What else do you assess? What's the very first thing you're doing when this patient walks in? Put her on fetal monitor. Okay. Maternal vital signs. Okay. So the fetal heart rate is in the 90s with no variability, no variability, late decels, no accels. Last menstrual period is unknown, but sometime in March or April. What's your action? Contact the provider. That's a category 3 strip, and they're probably going to go to emergency C-section. Okay. So now we're going to get that IV in. She's probably post-term. Okay. Next patient. The patient is full term, has had no known complications. Vaginal exam was 2 centimeters dilated, 100% effaced. Fetal head is at 0 station. The patient is screaming and about 20 minutes later states the baby is coming. What do you assess? You do a sterile vaginal exam again and select and assess for change. You also want to do fetal heart tones. And I saw a couple of people mention that. You also want to do fetal heart tones because if she's progressed that rapidly, fetal heart tones actually may show that. Okay. Fetal heart tones 120s with moderate variability, Accels. She's got variable D cells with good recovery to baseline. Dilation is complete. What do you do? Celine says, get help. Okay, so you call for help. You don't leave the room. You call for help. There is on every OB unit and in ERs, there is what's called a bib tray or a precip tray. Bib is for baby in bed. So you call out and you have someone bring the precip tray and contact a provider. You want to get a baby warmer turned on, but if she delivers very quickly, that warmer may not be warm by the time the baby is delivered. So you might do skin to skin at first instead. If you don't have a warm baby warmer, don't put the baby on a cold warmer. Those things are like French, they look like French fry warmers. Don't put a baby that's just come out on a cold French fry warmer. You want to keep the baby warm, okay? So precip tray comes to the room and with help, other people come, they bring or they get the warmer plugged in or turned on and the provider's on the way, but they're coming from 5 minutes away. This patient is pushing. So you don't have the patient go ahead and push. Sorry, just a minute.